So, again, good morning, all of you. So, today we will discuss benign and malignant disorders of the thyroid gland. So, okay, so the introduction of the thyroid. The word thyroid means the shield, which is the covering, the anterior part of the neck, and located in the anterior triangle of the neck. So, lies against the C5, T1 vertebra, extending from middle of the thyroid cartilage to fifth tracheal vein. And the weight, average weight of the thyroid is 20 to 25 grams, and the functioning unit is a lobule, which is supplied by single arteriole and consisting of 24 to 40 follicles lined by cuboidal epithelium. These follicles contain colloid in which thyroglobulin is stored. Now, this is the basic embryology of the thyroid development. You can see the thyroid, the buccal cavity, the path of descent of the thyroid, path of descent of the thymus, and tracheoesophageal tube. So, median bed of pharynx, which forms the thyroglossus cyst. It starts from the foramen cecum, vestigial laminate of the duct. Then third pouch, which forms the inferior parathyroid gland and thymus, and fourth pouch, superior parathyroid gland and ultimobrachial cortex. So these are the pouches which gives rise to the different structures. Then amalgamation of third and fourth pharyngeal pouches which descending thyroid lobe and completes the development. Now this is the basic anatomy of the thyroid. So it is complex as all the structures in neck are very challenging to operate, and you can see the external carotid artery and giving rise to the superior thyroid artery and vein. Accompanying the external carotid artery, there is the internal carotid artery, and by the side you can see the internal jugular vein and the branches, draining veins. You can see the inferior thyroid artery and the brachiocephalic tract. So you can also appreciate the right vagus nerve in between the artery and the vein. And then on the right side, you can see the supralaryngeal nerve also, which is leveled. Superiorly, thyroid cartilage is there, and below this thyroid cartilage, you can see the pyramidal lobe of thyroid gland and left lobe of the thyroid gland. Again, you can see the isthmus, left vagus, inferior thyroid vein, and the left brachiocephalic vein. Then the pretracheal lymph node, then aortic arch. So this is the basic structure of the thyroid gland with vascular supply. Now the relations of the thyroid gland. You can see the pretracheal fascia, relations of the medial surface. You can see the recurrent laryngeal nerve, esophagus, then relations of the lateral surface, sternocleidomastoid, sternohyoid, and sternothyroid, omohyoid muscle, then relation of the posterior lateral surface. You can see the carotid sheath containing common carotid artery, then internal jugular vein and vagus nerve. So this is the cross section at the level of thyroid. Now here is the lymphatic drainage. Basically, the external jugular node, sternocleidomastoid muscle, C beneath it. You can appreciate jugular digastric node, then deep lateral cervical node, intercollected node, then transverse cervical chain of nodes, and supraclavicular node, submental node, mandibular and submandibular node, internal jugular chain of nodes along the strap muscles, then superior thyroid node, then anterior superior superficial cervical node. So this is the basic lymphatic drainage which you should remember in thyroid malignancy especially. You have to appreciate this lymph node in relation to the different muscles like trapezius, sternocleidomastoid, posterior triangle, lower jugular node beneath the attachment of this sternocleidomastoid. Then anterior mediastinal node, central node. So there are different nodes. Now here is the pathophysiology of the hormone secreted by the thyroid gland. Basically, the main hormones are T3 and T4 secreted by the follicular cells. Calcitonin secreted by the parafollicular cells, parafollicular C cells located mainly in the upper one side of the thyroid gland. Then synthesis of this T3, T4, the tyrosine from thyroglobulin and this iodine from diet. This forms the follicular cells, which in turn gives rise to T3 and T4. Then coupling reactions, iodine along with tyrosine forms monoiodotyrosinase. Then this monoiodotyrosinase both combine to form diiodotyrosinase. Then this monoiodotyrosinase plus diiodotyrosinase they form the T3 hormone, which is the active form of the hormone. Then this diiodotyrosinase and monoiodotyrosinase they form the reverse T3, which is an inactive form, and then this diiodotyrosinase coupled to form this T4 enzyme. So this is the basic physiology of the hormone secreted by the thyroid gland. The functions of T3, it regulates BMR. T3 acts as a physiological uncoupler and increases body heat, thermogenic action, the metabolism, catabolic action, and developmental, intellectual, physical, and sexual development. Indirectly, increase the responsiveness of heart to catecholamines via beta receptors and increase heart rate and myocardial activity. Now, this classification of the thyroid swelling. This is the classification of the thyroid swelling. The thyroid swelling basically can be classified as congenital disorder, simple goiter, toxic goiter, neoplastic, and inflammatory. So this congenital disorder mainly ectopic thyroid, thyroid not present at its normal place, then agenesis, then dysharmoniogenesis, then thyroglossal. Then this simple goiter, which is euthyroid, and there's the T3, T4 hormones are in normal range. Then diffuse hyperplastic, which may be physiological, pubertal, and in pregnancy. Then there may be multinodular goiter, which may be euthyroid. Then toxic, there is diffuse Graves' disease, multinodular toxic adenoma. Then neoplastic, which may be benign and which may be malignant. Inflammatory, which may be autoimmune. Chronic lymphocytic thyroiditis and Hashimoto's disease, which is autoimmune. Then there may be decurrence thyroiditis, which may be which is granulomatous. Then fibrosis, which is Riedl's thyroiditis mainly. Then there may be infective, like acute bacterial thyroiditis, viral thyroiditis, subacute thyroiditis, and it may be chronic also, like tuberculosis. Right? Others are amyloid. So this is the basic classification of the thyroid swelling. Now, here is the congenital anomalies like ectopic thyroid versus ectopic lingual thyroid. These are different places where thyroid may develop. Intralingual thyroid, sublingual thyroid, retrosternal thyroid. You can see in the diagram line of different line, the foramen cecum, lingual, sublingual, suprahyoid, then thyroglossal cyst or ectopic thyroid, and pyramidal lobe, and retrosternal goiter. Then in congenital anomalies, there is agenesis, failure of development of the thyroid gland, then dysharmoniogenesis. Here is the picture of thyroglossal cyst. It is the remnant of the thyroglossal tract, most commonly subhyoid or infrahyoid. Then clinical presentation. There is midline neck swelling, moves with deglutination, moves with protrusion of the tongue. By these two, you can differentiate it from thyroid swelling. The diagnosis mainly by FNC, finite cytology, and USG neck to rule out the presence or absence of any swelling, any lymph node. Then management of the thyroid cyst is gold standard by the cyst trunk operation. This cyst duct, the central part of the hyoid bone, they all are removed. Then incision and drainage is contraindicated. It causes the recurrence. Now, goiter, diffuse hyperplastic goiter, you can see in the picture, it is covering all the region of the thyroid. And during iodine deficiency, it may be physiological, primary iodine deficiency, or secondary iodine deficiency. So there is diffuse hyperplastic goiter. Now there is multinodular goiter. Etiology mainly fluctuation of thyroid stimulating hormone, iodine deficiency, goitrogens, which gives rise to multinodular goiter, hereditary, and dysharmoniogenesis. Now pathophysiology here, diffuse goiter with variable stimulation of thyroid stimulating hormone. There will be hyperfunctioning, non-functioning, or normal. It gives rise to the mixed areas of active and inactive lobules. Active lobules with hyperplasia and increased vascularity causes hemorrhages with necrosis in center. Then there is a nodule formation. Multiple nodules with necrotic center and only internodular areas functioning. It gives to the multinodular goiter. Now, clinical features. It is more common in females than males. Slowly progressive disease. Form nodular, non-tender, and moves with debilitating. So the Foster test is there, which is positive. Then diagnosis is by T3, T4, and TSH levels. Hypothyroid, the TSH level increases. Hyperthyroid, the TSH level reduces. Then ESG of the neck. Then X-ray neck. There is a force calcification. You can see the micro calcification and indirect laryngoscopy should be done. Then management is total, subtotal, or partial thyroidectomy, depending upon the disease part of the gland. And post-operative L-thyroxine supplementation should be given. Now, discrete thyroid swelling, solitary or isolated thyroid nodule, discrete thyroid swelling is otherwise impalpable gland, solitary or isolated thyroid nodule. Then, dominant thyroid nodule, similar swelling with clinical evidence of generalized abnormality in the form of a palpable contralateral lobe or generalized mild nodularity. Risk of malignancy, isolated thyroid swelling, which is solid 24% and cystic 12%. Male it is 48%, in female it is 12% as far as solid is concerned, and in male it is 24% and female 6% as far as cystic is concerned. This is isolated thyroid swelling. When dominant thyroid swelling, in solid it is 12%, cystic it is 6%, and male 24% and female 6% as far as solid is concerned. The dominant thyroid swelling and male 12%, female 3% as far as cystic is concerned. Right? This is the discrete thyroid swelling. Now, clinical features you can see most common thyroid disease, surgical, and single palpable nodule. You can see commonest site at the junction of the stomach with one of the lateral lobe. The diagnosis is by USG neck, color Doppler, FNSC, USG guided being investigation of choice. FNSC is the first choice. The T3, T4, and TSS should always be done. Also because to make the patient euthyroid before operating, then radioisotope study, which is iodine 123 and 99 and technetium. Now here is the management: non-toxic, benign nodule, no role of hormone therapy, annual follow-up, hemithyroidectomy in case with comprehensive compressive symptoms or for the cosmesis mainly. The solitary oxy module, antithyroid drug should be given, radioactive iodine therapy should be given, and the need of hemithyroidectomy occasionally. When this colloid nodule, it is observed or hemithyroidectomy should be done. Then follicular neoplasia of undetermined significance, total thyroidectomy, and in malignant nodule treatment is based on the type of carcinoma and basically over the stage of carcinoma. So broadly, this is the management of non-toxic nodule, solitary nodule, colloid nodule, and follicular malignant nodule. Now, here is the retrosternal goiter. There are two types, mainly primary and secondary. 10% is primary, 90% is secondary. In primary, 10% ectopic thyroid tissue is in the mediastinum, and secondary 90% neck being the starting point which plunges into the mediastinum. The clinical features: the dyspnea because of the compression of the trachea, stridor, dysphagia, swelling. There is Pemberton sign, it is positive, and this retrosternal goiter. Now the investigation, you have to again go for T3, T4, and TSH. Then this radioactive iodine study should be done, which is diagnostic. CCT neck and thorax should be done. It is the investigation of choice. Then management is surgical removal of the thyroid by neck or cervical incision. Then sternotomy is only indicated in cases with malignancy, primary mediastinal goiter, then very large retrosternal part, then recurrence in the mediastinum. So these are four indications. Now here is the picture shown of the thing, the Graves' disease. And the active tall epithelium with light ruffulated cytoplasm, numerous colloid resorption droplets are there. This Graves' disease, it is an autoimmune disease, more common in females. Autoantibodies against thyroid receptors. These are the stimulating antibodies, long-acting thyroid stimulating antibodies, then thyroid stimulating hormone receptor antibody. These are the different antibodies, then present in association with diseases like pernicious anemia, myasthenia gravis, Addison's disease. Histopathological examination, scalloping of the colloid and tall columnar cells as seen in this picture. These are the clinical features, mainly features of hyperthyroidism. The thin, irritable patient with a weight loss despite good appetite. Then there will be tachycardia. There will be diarrhea. Then oligomenorrhea or amenorrhea. There will be tremor. Then eye signs, exophthalmos will be there. The Spielberg sign, infrequent blinking, first sign to appear it is. And their limbal sign, there is lid retraction. You can see in the picture, bulging eyes, eyelids are retracted, redness. So there is lid lag, known as von Graff's sign. Then Joffroy's sign, absence of forehead wrinkle. Mobius sign, loss of accommodation reflex resulting in convulsions. Diplopia. Then pretibial myxedema, dermopathy, thyroid acropathy, and dermopathy, clubbing, and subperiosteal bone formation. The diagnosis is by clinical features, mainly ECG to look for the cardiac involvement, T3, T4, TSI, then presence of autoantibodies. Then the management part, in children by antithyroid drugs like carbimazole and propyl thiouracil. In pregnant women, propyl thiouracil is a drug of choice. Then adult without goiter, antithyroid drugs followed by the radioiodine ablation. Adult with goiter, antithyroid drugs followed by the surgery. Then elderly with comorbid conditions, antithyroid drugs followed by radiofrequency. Then eye signs, antithyroid drugs followed by surgery. So this is the different management. Now here are the surgical options in the Graves' disease. You can see the total thyroidectomy and subtotal thyroidectomy. These two pictures you can appreciate. The thyroid failure, 100% in thyroxine supplementation has to be given in total thyroidectomy, and 100% risk of thyroid failure within 30 years. Then control of toxicity is immediate in total thyroidectomy. It is also there in subtotal thyroidectomy. The risk of this thyroid is immediate and up to 12 months. Risk of permanent hyperparathyroidism, 5%. And here is 1%. The need for follow-up is minimal in total thyroidectomy as whole gland is removed. Then there is lifelong need for follow-up in subtotal thyroidectomy. The specimen you can see both thyroid lobe and isthmus the first, and thyroid lobe and with isthmus second. Now there is Hashimoto's thyroiditis. There is lymphocytic thyroiditis, an autoimmune condition, more in females than in males. Then association with HLA, DR3, B8, Down syndrome and Turner syndrome. Then autoimmune antibody formation, blocking antibody against thyroid receptor. Then TPO enzyme and thyroglobulin. Now pathophysiology, Autoantibodies stimulate lymphocytic infiltration, destruction of the healthy follicles, stored release transient hyperthyroidism, and repeated attacks and no resolution destroys follicles, Hashimoto's thyrotoxicosis, and prolonged hypothyroidism. Clinical features, early stages, features of hyperthyroidism or patients present with hashimotoxicosis, symptoms of hashimotoxicosis, there will be fatigue, sweating, goiter, then tremors in the hand, intolerance to heat, changes in the mood, the change in the bowel movement. The prolonged cases, features of hypothyroidism, dull and lethargic, alopecia, then bradycardia, constipation, weight gain, cold intolerance, menorrhagia, and diffuse enlargement of the thyroid gland, and in long-standing cases, thyroid lymphoma. This is a slide of the histopathological examination. There is lymphocytic infiltration, Hurther cells. You can see diagnosis is by autoantibody levels in the blood, management by L-thyroxine supplementation, and if the diffuse thyroid goiter is present, then surgery is required. So from here onwards, we will cover in next lecture. Thank you to all of you.